All right, welcome back to the Progressive Rehab and Strength Podcast. I'm your host, Dr. Rori Alter, here with my lovely co-host, Dr. Alyssa Haveson, a clinical coach here at Progressive Rehab and Strength. And we've brought on another clinical coach here at Progressive Rehab and Strength, who you've heard on the podcast before if you've been around a little while, Dr. John Petrizzo. He is not only a physical therapist and barbell strength and powerlifting coach, but he is also a professor at Adelphi University in the exercise science department. And we're bringing him on today to have a discussion all about the biomechanics of the knee joint in barbell training. So the purpose of this episode is to bring more knowledge to lifters about the structures involved in or around or part of the knee joint, how the knee joint actually moves in normal human movement, connect that to barbell training, and then talk about how this stuff it might be influenced by pain and injury or might influence pain and injury. But before we dive into understanding that, we do want to remind you that pain in a particular area of the body or with a particular movement in barbell training is not only or always related to a structural issue in the area that you're experiencing pain. So we have a full episode, 3 full episodes discussing pain and injuries in barbell training. So we'll link those in the show notes for you guys. But the pain and injury series is a really good place to start if you're experiencing any pain in your knee in barbell training. So, John, tell us a little bit about the knee joint and its structural, I don't know how to say it, just the structure of the knee joint and how it moves in space, both from a joint perspective and a larger perspective within the kinetic chain.
Okay, sure. So the knee is really comprised of 2 separate joints. So we have the patellofemoral joint, which is essentially the interaction between your kneecap and your femur. And then we have the tibiofemoral joint, which is the interaction between the tibia and the femur. And those 2 joints really have 3 distinct compartments. So the tibiofemoral joint has a medial compartment and a lateral compartment, and then there's the patellofemoral compartment. So together, those joints basically function simultaneously to produce the different movements that we get at the knee. And the knee is a relatively simple joint in terms of movement. So it primarily just flexes and extends. We would say that it has 1 degree of freedom. So the number of degrees of freedom a joint has indicates the number of different planes that it moves in. So we have 3 different planes of motion. You have your frontal plane, your sagittal plane, and then your transverse or horizontal plane. So the knee primarily is going to work in the sagittal plane when we flex and extend it. So it has 1 degree of freedom. So it's pretty simple from that standpoint. Where it gets a little bit more complex is that there is some rotational movement that occurs at the knee joint as it flexes and extends. The reason that we don't consider that all that much when we're talking about its function from a mechanical perspective is because we don't have any voluntary control over that. So that's really the result of the anatomy. So the femur is slightly twisted. It has a torsion angle in it. All right. So if we're looking at it from the hip, we call it the angle of torsion, which is where the femoral head and neck sit relative to the condyles, which are down at the bottom of the femur. And then the tibia also has a little twist in it or torsion angle. In addition to the fact, so those 2 compartments that we talked about, the medial and lateral compartments, aren't equal in size with each other. So the medial compartment is much larger than the lateral compartment of the femur, so of the knee. So the medial femoral condyle is larger than the lateral condyle. The medial tibial plateau is larger than the lateral. So because of these essentially twists or slight rotations that we have in the femur and the tibia, and the difference in the size of the medial and lateral compartment of the knee, as we flex and extend, there is going to be some rotational movement of the knee, but it's not something that we voluntarily control. We voluntarily control the flexion and extension that occurs. So hopefully that makes sense.
You're muted. I have a question. So, you know, I don't know the statistics on this from a research perspective, but in my clinical experience, there's more medial meniscus tears than lateral meniscus tears. Would you say that that's kind of?
Oh yeah. So we weight bear more through the medial compartment versus the lateral. So there's a higher incidence of medial meniscus injuries versus lateral. There's a higher incidence of MCL injuries versus LCL injuries. There's also a higher incidence of osteoarthritis in the medial compartment as opposed to the lateral compartment. So the medial compartment is larger, but we do put more compressive force through the medial compartment, and that is most likely the reason why we see higher incidence of pathology in that part of the knee.
Would you also say that because it's larger, there's more motion that's occurring in the medial compartment, and that might also be contributing to it?
Well, so if we're talking about like stress on the medial side of the knee, then we have to talk about valgus and varus stress. So valgus stress is a type of stress that is applied from a lateral to medial direction versus varus, which is the opposite. So it's a medial to laterally directed force.
So for people, John, for people who don't know the terms or understand the anatomy and the term medial lateral, like what does that look like? That's from outside to inside and inside to outside of the knee, correct?
Right. So from lateral to medial, it would be from outside to inside. And then vice versa for varus stress. So medial to lateral be from inside to outside. So at the knee joint, we tend to have more valgus stress as opposed to varus stress. So we tend to have more stress applied in that direction. And that has to do with the interaction between the hip and the knee, and to a certain extent, the foot and ankle as well. So the knee joint, the way I look at it, it works together with the hip and the ankle, and it's in between those two different joints, right? So various different issues that can come up in regards to the hip and the ankle can have an impact on the knee joint. But so, for example, one of the things that we look at is called the Q angle or quadriceps angle, and that's essentially the difference between the lateral part of the hip and the center of the knee, and the resulting difference between those 2 points. For most people, it's going to be somewhere between 10 and 20 degrees on average. But that is a contributing factor to why we have more valgus stress at the knee joint, because our hips are a little bit wider, right, than our knees are. Something at the ankle, so like pes planus, or having an overly pronated foot and ankle in a resting position where you have a decreased arch, right? So you could say you have flat feet. That can contribute to a little bit more valgus stress at the knee as well. So there are all these little things that can contribute, but for just about everybody, you're going to have some sort of difference between the hip and the knee joint in terms of that Q angle, and that contributes to having a little bit more valgus stress at the knee, which then applies more stress to the medial part of the joint.
And just to clarify for people who are concerned about the term stress, all of this is like normal in the human body. So this is just the anatomical structure that we have, and it functions, it's designed this way for our muscles and our body to move in space well. And so the Q angle, like, you don't have to get so obsessed with the Q angle and flat feet and varus and valgus stress and all that stuff, because this is the normal position, and everybody's going to have their normal, whatever they were born with. So like I have flat feet, and I have we can also talk about genu recurvatum, but I have like hyperextended knees. I have valgus at my knees, and my knees don't hurt, so we don't want you to hear this word stress or the fact that we're talking about this anatomical structure of the human body and think that, oh shit, that's bad. This is just normal, but this is why people tend to get more symptoms or injuries on the medial side of the knee versus the lateral side of the knee. Does that make sense? Now,
Yeah, I
Alyssa,
think
oh,
that's
sorry.
well said. No, that's okay.
Now, Alyssa, I know that you are, this is going to be, we didn't outline this episode, so there might be some rabbit holes that we go down. But Alyssa, I know that before we started recording, you kind of wanted to discuss how the hip and the ankle or foot might influence the knee, but I think that this can kind of tie into a larger issue that you are passionate about, which is the knees out cue, and not letting your knees cave when you're squatting, because we've seen a lot of people talk about like it's okay to let your knees cave in. Don't focus so much on shoving your knees out. But I think that what we should talk about is the importance of keeping your knees in line with your feet throughout the execution of the squat, right? So, Alyssa, that's something that you're passionate about.
Yeah, and I think that the knees out cue is good, and I use it frequently, but we can have too much knees out. We can have too much knees in. And if your knees are coming in, that does not mean you're going to have pain or you're going to, end up with an injury. We just want to optimize movement. So ideally, we really want to keep the knees in line with the direction of the toes. And the thing is that that's really not so much of a knee issue. That's what's happening at the hip and also what's happening at the foot and ankle. So, what we were talking about before this is really oftentimes what's going on at the knee is not an issue of the knee or directly related to the knee movement. It's related to the hip movement and foot and the ankle. And the knee is really this joint that's kind of stuck in between the two. Uh, and
Well, I
and
think no,
it's almost like
I totally agree. I think that's really important to mention that the knee is kind of like the transfer of movement from the hip and the foot and ankle, right? And when John, you mentioned that there's really only 1 degree of freedom in the knee, and at the hip and the ankle and the foot, there's a lot more movement. So we shouldn't be getting, and correct me or chime in here if you feel like there's a better way to say this, but we shouldn't be getting so much movement of the knee in space in the medial lateral direction when we're squatting because of or we should try to limit the amount of medial lateral movement of the knee when we're squatting because of that knee joint really only has that 1 degree of freedom. Like we don't want to create so much stress on either side of the knee because we want to keep it in its normal anatomical alignment. Does that make sense?
Yeah, I think that makes total sense. And I would agree with Alyssa. I mean, obviously, we don't want to, you know, you see people certainly under maximal loadings and maximal effort, there's always going to be some form breakdown. And it's pretty common to see a little bit of, increased valgus at the knee or the knees moving in medially. That doesn't, I mean, I should say it's very rare to see really like traumatic acute knee injuries with lifting, right? So when we are talking about injuries in lifting, usually we're talking about more, nagging aches and pains versus like any sort of traumatic injury like you see in more typical team sports like football or basketball, where you see people tear their ACLs or MCLs or rupture their quad or patellar tendon or something like that, right? Um, but So yeah, you're going to see some of that, but certainly I think from a mechanical standpoint, it makes sense to try and limit that and keep the knee in a fairly neutral position. It's not optimal to have your knees shoved way outside of your foot, which is a cue that I think sometimes gets overdone when you tell people knees out, and it's not optimal to have them collapsing in significantly from its alignment with the ankle. And just to kind of expand a little bit on what Alyssa was talking about in regards to the hip. So when you see the knees collapse medially, it's not really an issue of the quadriceps or the hamstrings, which are the primary muscles that are flexing or extending the knee joint. It really is a failure of the hip abductors, which are your glute medius and minimus, and to a lesser degree your TFL, and their ability to maintain the femurs in a slightly abducted position while you're squatting, right? Because most people are going to squat with their toes turned slightly out. That's going to be more comfortable for them. They're going to be able to hit depth easier. And the degree of toe out varies for a variety of reasons, hip joint alignment and things like that. But when you see the knees collapsing in, it can be an issue of weakness in some of those hip muscles, or it could be that the foot and ankle are pronating and the arch is collapsing when we really want it to be in a more neutral, type of position. So like Alyssa was saying, it's coming from the hip or the ankle. It's not actually a knee issue, right? So I think that's important for people to understand.
Yeah, and I just wanted to add, and I think we should talk about the function of the quad and the hamstring, and the knee angle. So like depth, I guess when we talk about the knee angle at the bottom of the squat, actually it's more related to depth and torso position. So bar and torso position. So we'll talk about that. But the knees in, like when the knees cave in, it's not over time. Everything is kind of like a load management and a time, how many exposures, and are you recovered enough, or are you able to handle that exposure, but when you get to the sticking point of the squat, and this is really about, we want to put our muscles in an optimal position to fire and function. So fire well. Our muscles are always firing. That's another topic for another podcast episode. But we want to put all of our muscles in a position to recruit the most amount of motor units to lift the most amount of weight possible, right? So when our knees cave in, and really it's the knee caving in thing is more of an indication that something's not working well at the hip or the ankle, right? It's because you can't cave your knee in by caving your knee in. It caves in from the hip, which we've been discussing. But when you get to the sticking point of the squat, which is the hardest part of the squat to overcome, if the knees are medial of the foot, so if they've fallen inward of the foot, so you have some knee collapse, your hip abductors, external rotators and hip extensors are not in an optimal position and neither your quads really, or your adductors, they're not in an optimal position to overcome the force at that moment. So we want to keep our hips, our knees in a good position throughout the lift so that we can continue to power through the sticking point. So you tend to see, I would encourage you guys to watch people fail squats and see what their knees are doing when they fail. And they typically can't keep their knees in line or get them back in line with their feet to continue to power through the sticking point of the squat. John, you look like you have maybe a rebuttal for that or some thoughts.
No, not really a rebuttal. I think, when we're talking about that alignment of the knee relative to the hip, so the muscles that are going to change length based on the position of the femur relative to the pelvis, right, are primarily going to be, like you said, your external rotators, your abductors of your hip, and your adductors. It's not really going to be so much your quadriceps, because the quadriceps, 3 out of the 4 of them don't cross the hip joint, right? So I actually don't think that if the knee collapses in, it's probably not having that much of a negative impact on your quadriceps function as it is the other musculature that's working to extend the hip. So your knees will probably be able to continue to extend even if they're not in a great anatomical alignment, but I think it's going to be more of the hip musculature that's going to be impacted. And specifically, if we're talking about the knees collapsing in, you can't really use your adductors as effectively to extend the hip, to assist with hip extension, because they're going to be getting shorter, as the knees come in.
Would you also say though that the glutes are being over lengthened when you adduct the femur or internally rotate the femur? Are the glutes lengthening too much and they're kind of in this passively lengthened position where they can't contract as well?
Yeah, I mean, that's possible. So your glute max is going to basically insert onto the IT band, and the glute medius and minimus, they insert into the greater trochanter of the femur. So if the femur is moving inward, then yeah, you're going to get some lengthening of those glute muscles. How much is that, and does that impact their function? I think it would be hard to say. I haven't seen like EMG research on that, so I couldn't really comment. But in theory, I would agree that, yeah, they're going to lengthen a little bit, which may not allow them to contribute as much.
All right, so let's talk about structure and function of the muscles surrounding the knee joint, because you just mentioned that when your knees cave in, when you get this adduction and internal rotation of the femur, it doesn't allow the adductor muscles to contribute to hip extension as much. So tell us a little bit about the thigh musculature that crosses the knee joint and contributes to knee flexion and extension. So let's talk a little bit about that.
So like you said, I mean, the quadriceps are really your only knee extensor musculature, right? So that's 4 different muscles, only one of which crosses the hip joint. So that's the rectus femoris. The rest of them only cross the knee joint. They all come together to form the quadriceps tendon and the patellar tendon. So, which are really just one continuous piece of connective tissue. They just refer to the quadriceps tendon as a portion of the tendon above the patella, and the patellar tendon as a portion of the tendon below the patella. Sometimes you'll see that referred to as the patellar ligament as well. But that is the tendon that connects the quadriceps to the tibial tuberosity, that little bump on the front of your tibia, and those muscles are the muscles that are responsible for extending the knee. They also function in our everyday life and during lifting, especially if we're talking about the squat. They control knee flexion by working eccentrically, meaning that they're lengthening as they're producing some force. So we think about like walking down the stairs, right? You take a step down, the leg that's in contact with the higher step, right? That knee is going to be flexing, and those quadricep muscles are going to be controlling the knee flexion as they lengthen, right? They're exerting some force to allow for that to happen. So it's the same thing as you lower yourself down in the squat. The quadriceps are eccentrically lengthening to help control the speed of the movement.
And that's why it hurts so much to go down the stairs the day after a heavy volume squat day or your first day back to squatting after a vacation or a competition, when you've gone from low volume to high volume.
Yeah, that's right. I mean, so they're very active eccentrically in a lot of what we do, and we know that eccentric muscle actions are more closely associated with delayed onset muscle soreness, right? So then you have the hamstrings, obviously, which the hamstrings are a biarticular muscle, so they cross 2 joints. So they attach proximally at the ischial tuberosities, which is the posterior part of your pelvis.
Your sit bone, so those
right.
bumps on your tush that hurt
And
when
they
you ride a bike.
So they contribute to hip extension, but people most commonly, I think, associate them as being knee flexors, because if you think about in the gym, right, any sort of leg curl machine, that's always been known as a hamstring machine. That's really only working one of their 2 functions, right? So, and the hamstrings are comprised of 3 different muscles. So you have the biceps femoris, and then the semitendinosus and membranosus. So those 3 muscles all attach proximally to that ischial tuberosity, and then they attach to slightly different points of the tibia and the fibula. So the biceps femoris attaches to the fibular head. so those are your primary knee muscles, but the so the gastrocnemius, which is your most superficial, largest, strongest calf muscle, that inserts distally to the Achilles tendon and your calcaneus or your heel bone, actually crosses the posterior side of the knee and attaches to the femoral condyle. So, so the gastrocs assist with knee flexion. That's if anybody has ever done like a glute ham raise or something like that. You'll feel the hamstrings working, but you'll also feel the calf muscles working pretty hard. And even on a leg curl machine, you'll feel the calf muscles, kind of kick on to try and assist with that knee flexion. And then, so in terms of the adductors, there's only one adductor that crosses the knee joint, and that's the gracilis. And that crosses the posterior side of the knee and attaches to the proximal medial side of the tibia. So they assist, the gracilis assists the hamstrings with knee flexion as well. So we have a couple different muscle groups that help with knee flexion. Only the quadriceps that assist with that perform the function of knee extension. And then again, we're talking about how these other hip muscles like the glute medius and minimus and gluteus maximus, right, and TFL and some of these other muscles can contribute to what we see at the knee because of their role at the hip, right? And adductor magnus would be another one of those as well. So, so even though not directly flexing or extending the knee, they're gonna help position the femur. So that's going to change what we're observing, like when we're watching somebody squat and that sort of thing. So that's why really all of these muscles work together as a system, to help us perform these big, like multi-joint movements that we're performing when we're lifting.
Awesome. I think that if you're listening to this episode, rewind a little bit and pull up an image of the muscles of the knee and hip, or just the lower extremity from the front and back side. And this stuff will make a lot more sense if you pull up an image. And for the YouTube video of this, maybe I'll try and stick an image on the screen if I have the patience to add images to this video. So John, can we talk?
You do YouTube videos for these things?
No, we just started just recently.
Oh.
So not all of the
episodes
are on
news to me.
Well, I know you I thought our podcast producer said that a lot of people only listen to podcast episodes on YouTube. And I think that you listen to some episodes on YouTube from some different podcasts, but maybe not. I don't know. I see you on the row where you have a video up and you're listening to something. So I don't know if it's YouTube or not, but whatever. But can we talk a little bit about I want to talk about the role of the menisci and the joint cartilage and also the patella. Because when people have injuries at the knee, they'll get images and be like, oh, I have a meniscus tear, or my patella is sitting off to the side, or it's misaligned or malaligned, or I have no cartilage in my knee. Like, what does all this stuff mean? John and I are actually sharing a client right now who has some pretty significant arthritis and knee joint or patellar hypomobility. But okay, so let's just go to these structures. You tell us a little bit about the structures, and then going to preface this with, you can have end stage arthritis in your knee and have zero pain. And you can have a meniscus tear. You can have multiple medial and lateral meniscus tears with no pain. You can have an ACL tear. You can have your ligaments can be torn, and you can be totally asymptomatic. The research shows us this. There's so much research that shows us this. But you guys are going to go to the doctor. You're going to get images. They're going to use language that scares you. You're going to see something different on one side versus the other side, and you're going to be like, what the heck? So, John, tell us a little bit about this.
Okay, so the menisci are fibrocartilaginous, semilunar shaped discs that are attached to the tibia that essentially provide they actually have a variety of functions, but they provide cushioning in between the tibia and the femur. So they're like shock absorbers, right? So they assist with shock absorption and load transmission in the knee. They also actually help to keep the underlying articular cartilage healthy by helping to compress synovial fluid into the articular cartilage, which the synovial fluid relies on for maintenance and repair and things like that. And they also assist with guiding movement. They make the joint a little bit more stable because of their shape. So if you look at the structure of the knee joint, you have these rounded femoral condyles and these relatively flat tibial plateaus. So the menisci and the four primary ligaments of the knee, the ACL and PCL and MCL and LCL, really assist with the stability of the joint. So that's really the menisci, and very common for people to develop fraying in the menisci, some tearing, things like that over time. What research has kind of shown is that removing the menisci leads to faster breakdown of the articular cartilage, right? Because they're like these little buffers in between the femur and the tibia. So even just a removal of part of the meniscus, right? So what we would call a partial meniscectomy, which is a more common type of arthroscopic procedure that gets performed on people that have a meniscus tear, has been shown to have negative consequences in the long term on the underlying articular cartilage. So, it's a very common type of thing. I would tell people, if you've been diagnosed with a meniscus tear, I would not rush into surgery. Certainly, there are cases where it's warranted, like if the knee is catching, locking, getting stuck, in a position of flexion or extension or something like that, then that's a sign of probably a larger tear that maybe needs to be addressed surgically. But most of the time, I would tell people to, just kind of proceed with caution. Something else to keep in mind. So the menisci transmit more compressive load, or I should say more compressive load is transmitted through the menisci as we go into deeper degrees of knee flexion as opposed to extension. So if you have a meniscus injury, you may need to modify the range of motion of your lifts or something like that for a period of time, and then gradually increase your tolerance to it. But so that's maybe something to kind of keep in mind, if that's something that you're dealing with. But yeah, I would certainly say they're very important. Just like many parts of the body, right? They're prone to breakdown over time, but that doesn't necessarily mean that you should go and run and have them addressed surgically.
Yeah, we have a 10-minute tip episode coming out after this episode to discuss should you have a meniscus repair or arthroscopic surgery to address the meniscus or not. So
right, a repair. Oh, sorry. I'm sorry. A repair and a partial meniscectomy are two different scenarios. Yeah.
But so we were hoping to have you on for that 10-minute tip, but I don't think we'll have time because I know that you have to go. But so we'll talk more in depth about signs and symptoms or plans of care to rule in or rule out surgery for a meniscus injury. But talk to us a little bit about the patella and its role, function, and why people get anterior knee pain or patellofemoral pain.
So the patella is the largest sesamoid bone in the body, which means that it's embedded in a tendon, which is the quadriceps and patellar tendons, like we talked about before. And it actually has a really important biomechanical function. So what the patella does is it pushes the quadriceps and patellar tendon further away from the center of the joint, right? And what that does is it increases subtly, but it increases the angle of pull that the quadriceps has on the tibial tuberosity. So what that means is that it increases the steepness of the angle at which the quadriceps attach to the tibia. Now, when we're talking about angle of pull and we're talking about mechanics, so the most efficient angle of pull we can have is 90 degrees. So if the muscle's pulling on the bone right at a 90-degree angle, then all of the force that the muscle is generating is going to be transmitted efficiently into the bone. At angles that are greater or less than that, we're going to lose some of that force transmission to the bone because of the difference in angle of pull and the fact that instead of being in pure moment, right, or torque, rotational force, however you want to describe it, there's going to be some of that lost in compression or tension. Okay. Now, so essentially, by increasing the angle of pull that the quadriceps have, you're increasing the leverage that they have to extend the knee. So it makes the quadriceps job of extending the knee easier. So the patella is very important. Years ago, if someone had a bad patellar fracture or something like that, they would actually remove it. When I first started working as a PT, I had a patient that had years prior had their patella removed. Now they know that that's not a good idea, right? So they will replace the patella. They will, if it's fractured, they will surgically repair it, and things like that, because they know that it has an important biomechanical function.
And a knee without a patella looks so weird. Like, so weird.
It does.
We don't need this.
We don't need this. Let's just take it out. And even the repairs, I mean, that's an interesting surgery to work with. But when they repair the patella, that has a whole other host of issues. But it's better to have the patella with the repair and those issues than to not have the patella.
For sure.
Can you talk? So I just want to talk about two things. So let's quickly wrap up the patella, and what I want the first thing that I want to talk about of the two things is tilt of the patella, because people will get diagnosed with like a laterally tilted patella, and they're like, it's out of alignment and it's blah blah blah. So what does that mean when people get imaging of their patella and they're told that it's been shifted or it's lateral? Is this a new thing in their body, or has it always been that way? So what does that mean? And then I want to quickly after that talk about the IT band and lateral knee pain, ITB syndrome. But
okay,
we only have like 5 minutes left. So
all right. So in terms of patella, so if someone is diagnosed with something like that, right, like a laterally tracked or tilted patella, that's probably something that's structural that they've had their whole lives. That maybe has just become symptomatic because they've taken up some new activity or whatever the case is, right? There are several factors that will contribute to that. One of those would be the Q angle. So the larger the Q angle is, the more lateral pull there's going to be on the patella when the quadriceps contract. Some other ones are structural, right? So some can be the size of the patella. Another one can be the femoral condyle. So the femoral condyles, essentially the patella should glide in between those condyles as the knee flexes and extends. So when the knee flexes, the patella should slide down in between the condyles. And when the knee extends, the quadriceps contract and pull the patella up through that groove in the condyles. So if someone has, let's say, a fairly shallow groove, right? It's not as deep as we would expect to see. That can lead to some malalignment of the patella. If the lateral femoral condyle, the height of that condyle is not as high as we would typically expect to see, then that can lead to some sort of misalignment of the patella. So, in very rare instances, do they have to do like surgical procedures sometimes to help like stabilize someone's patella that's really out of alignment and they have some of these structural things going on? Yes, but it's very uncommon, for that to be the case. So yeah, if someone has that type of diagnosis, it's probably something that they've had, for a long time, and just never really knew that was, unusual.
yeah, and I just want to I try to use the word atypical, not that you're saying anything wrong, because everyone says malalignment. But I think that, when we're talking about like, this is what your structure has been your whole life. It didn't all of a sudden get into that position and start moving there,
Mm-hmm.
So I like to just say like atypical because it's not what we normally see. But doctors don't really like to perform patellofemoral surgeries. They are very uncommon and they're almost like last resorts because they're huge.
Yeah.
And even from my own personal experience, I have a cartilage tear that has been throughout my life, has had episodes of really extreme flare-ups in my knee. And my doctor, because of the level of competition that I do and how high I compete, he was like, I'm not doing this surgery on you because they're just patellofemoral surgeries are just too big and the outcomes are just not as great as we would want them to be. So he was like, keep training. Thankfully, I have a doctor who's not like, don't ever squat again. But it's about modifying things and reducing the load and reducing the stress and allowing the knee time to recover. So it's always about load modification, range of motion modification, movement modification, frequency, like all these things to allow the knee to stop hurting and continue to train, because we don't have to jump to injections and shots and all that, injections and surgery and all that stuff all the time. But I know that you need to go shortly because you have a call that you have to jump on. So quickly, what is IT band syndrome? Even though that's the whole rabbit hole.
So IT band syndrome, I think, is typically described as pain on the lateral, distal portion of the IT band around the area of the lateral femoral condyle, and it's thought to be caused by increased friction between those two structures. Commonly seen in endurance athletes like runners. I don't think it's as common in lifters, but again, based on your training and what you're doing, is it possible to kind of flare that up? Yeah, sure.
I typically see lateral knee pain that presents like an IT band syndrome in people who overshoot their knees out. So
Mhm.
if you're excessively pushing your knees out beyond your feet when you squat, and this isn't a very common thing, but that can be a contributing factor. And then sometimes it presents itself in the bench press as well. When you have a very externally rotated foot placement and a strong leg drive, you can sometimes get IT band with that, IT band syndrome with that. But that tends to be coming from the isometric contraction and the position and contraction of the hip musculature. In the bench press. But anyway, for people who don't know about the structure and function of the IT band, what does it do? Where does it insert and start? All that stuff.
So it originates up by the hip. The TFL, the tensor fascia lata, and the glute max have insertion attached to it. They have fibers that attach to it, and essentially the way that I describe the IT band is that it's kind of like a long tendon, in terms of structure, so it's a long piece of connective tissue that essentially connects your hip down to your knee. So it has fibers that run into the lateral portion of the knee and to the fibular head. So, there's talking about the patella, right? I think kind of a little bit more of an old school train of thought is that, like, if your IT band is too tight, you're going to have more lateral pull on the patella, and then you need to strengthen the VMO, and all these things that we know is not really the
We should
case.
do
But
a
essentially,
mythbuster,
it's a
episode. Muscle, like glute amnesia and the VMO. Anyway,
yeah, yeah. No, I just got a new patient who's patellofemoral pain, and the doctor is very into VMO strengthening exercises. Whole protocol focuses on VMO, so it's going to be interesting trying to explain to the patient that that doesn't actually exist. But um, so yeah, it's just basically a piece of connective tissue that connects your hip to your knee.
Yeah, and I would say that lateral knee pain that we are identifying as kind of this IT band pain region is usually a symptom related to the hip and not the knee. So that's kind of like what Alyssa was talking about at the beginning. We have to address what's going on at the hip to help address the symptom that we're experiencing at the knee. So,
so pain from your IT band is probably, it should be proximal to your knee joint, it should be above your knee joint, right? So it shouldn't be like on the joint, more times than not. If we're talking about IT band syndrome, the pain is above the knee joint on this outside of the thigh.
Yeah. So it's like lateral and superior kind of region if we're looking at the knee. But it can go kind of like all the way. Sometimes people can have pain all the way down into the insertion on the fibula as well. So it just depends. But everything always depends. So everything always depends. Will you need surgery? It depends. What have you done to address the issue? What is the issue? 9 times out of 10, we'll probably tell people you don't need surgery. So we're going to want to have a 10-minute tip to talk about meniscal issues specifically and how to determine if you should be considering surgery or not with your diagnosis of a meniscal tear. And can people actually diagnose meniscus tears without an MRI? Probably not. Maybe. But anyway, thank you, John, so much for jumping on for this episode. We're going to do the hip. We're going to do the other joints of the body, and we'll bring John on for those as well. We could do these episodes, but John teaches this every 3 semesters a year for the last 10 years. So we figured that it was best to bring John on because he could just shoot this out like nobody's business. So we appreciate you, John. And if you want to connect with John, he's at John Petrizzo on Instagram, John with an H. You can check him out on our website. And he often shows up on my stories on Instagram as well. So thanks, John. We appreciate you.
Thank you, John.
We'll see you soon.
All right. Thanks, guys.